Good evening. On behalf of President Bill Law, the faculty, staff, welcome you to St. Petersburg College tonight. We are very pleased to sponsor our third forum on healthcare reform tonight. We all know that the healthcare system faces many challenges, such as the economic pressures to decrease costs, the increased need of technology in healthcare. We also need to maintain quality. And tonight's program will focus on the initiatives of the Florida Hospital Association to improve quality and patient safety. At this point, I'd like to introduce David Clement, Executive Director for the Institute for Strategic and Policy Planning here at the college. David?
Thank you, Dr. Nicotera, and thank all of you in this small but hopefully dedicated audience for attending this third and final forum in the Institute's series on healthcare and the implications of the federal law. I'm excited to represent St. Petersburg College through the Institute for Strategic Policy Solutions. I'm now 1 month into my tenure here as Executive Director of the Institute, and I'm privileged to stand here to launch this third and final forum in this series. Much of the credit for the success of the series up to this point must go to Janet Long, who has been working diligently to make it a success it has been. Janet will be on stage shortly to facilitate the questions and answer part of the program, but I wanted to take this opportunity to publicly thank her for all the work she's put in to create this series and let you know what a tireless worker she is, and also the fact that she knows everybody in Pinellas County. I mean, everybody. The Institute, just if I can take a minute for a little bit of background, has been a long time in the planning, going back to 2007 under the leadership of then President Carl Cutler Jr. It has been unofficially underway for about a year, starting with the Gulf oil spill last summer, when the Institute got its toes wet, pardon the pun, with a 3-part series on the impact of the spill on Tampa Bay. And it presented 2 forums in this 3-part series on healthcare reform this winter, January and March. And with this third and now official directorship by me, we are official, and we hope well into our role, one of our roles, as a facilitator of community discourse. We're busy working on a full agenda of programs, and I want to just notice, and we will notify you by email if you want to be. If you don't, please let us know to be taken off. But of some of them, but I wanted to highlight one of them, which is one of the more exciting ones is called the Village Square. This is a 21st century version of that traditional small town meeting where the community of civic-minded people used to gather to discuss issues of great importance to them. Well, you know that, I wanted to say, gather to civilly discuss those issues, and that's what the emphasis of this forum will be. It will be a 4-part series, one each quarter during the academic calendar year. It will be a membership event, and people will join. There's a limited number of memberships depending on how much our hall will seat. It was founded in Tallahassee, co-founded by our president, Dr. Bill Law, to provide an option for the shout-outs that passes for civil discourse today in much of our debate in this country. This is a bipartisan and politically neutral venue in which the top issues of the day are discussed. My wife and I went to these programs in Tallahassee, and I want to tell you that you leave there feeling intellectually stimulated, informed, involved in something important, and also well-fed. Did I mention that there's food? So watch for a notice of membership openings for that. But now let's get to tonight's program. We know that national health care has been an issue of great controversy in this country for well over a year now. Perhaps you saw some pickets at the drive entrance to the campus as you came in, indicating that it's still controversial. We would like to think that these programs have helped expand understanding of the law, and we've tried to explore the facts and the myths about it in part one, and in part two, its impact on providers. Tonight, I hope that the focus of this program will add to the understanding as we delve into one of the more positive aspects of it, quality care, and how that both improves patient outcomes and cuts overall health care costs, which is a benefit to the patients and as well as to the bottom line of the service providers. Our speakers will offer two perspectives on that facet of a healthcare service, and then we'll open the floor for questions. We ask that you write your questions on cards, that if you didn't get one when you came in, and just raise your hand and one of the staff will pass cards out, and then we'll collect them as I'll be watching for them, and I will collect them for Janet, who will be facilitating that part of the program. Our first speaker is Stephen Mason, who is president and CEO of BayCare, a community-based healthcare system in the Tampa Bay area with more than 18,500 employees. He holds a master's in hospital administration. He is former chairman of the board of the Florida Hospital Association, former board chair for the Tampa Bay Partnership, and former board chair of the United Way of Tampa. Mr. Mason. And thank you. Our second speaker will be Martha DeCastro, who is Vice President for Nursing with the Florida Hospital Association, which represents more than 165 hospitals and healthcare systems, as well as 1,750 professional members. She is certified in infection control and is often called upon as an expert in testimony to make presentations in that field. She holds a Master's of Science in Health Administration from Nova University. Ms. Castro. And now Mr. Mason will open the program.
Thank you very much. I'm delighted to be here. In your past forums, you've had an opportunity to look more in depth around the law, and I'm not an expert on the law. I won't profess to be an expert on that law. But much of the law is about insurance reform, not healthcare reform, and doesn't speak specifically to activities that we can work on to improve healthcare in the organization. The real exception is in the area of quality, and that's what Martha and I are going to talk to you about tonight, is quality and what we in Florida, with the Florida Hospital Association, are looking at to try to address the specifics. And as it looks to quality, the law has tried very much to look at how do we create a new system that allows for the cradle-to-grave care for our communities, that allows for us to be able to create an incentive and a payment process that will give us a much better position around early detection, prevention, and management of chronic care. Because most of the delivery of care that we're doing now is under what we call rescue care, where people are sick and they go to the hospital or they go to a physician's office and receive care. There's very little financing that focuses on population health, the prevention of disease, and the focus on how to improve the lifestyle and how to provide education to help people do a much better job. And then those that are in a chronic state, how do we manage that chronic care much more effectively. So underlying all of the discussion, I think the most important part of this law comes back to what healthcare really is all about, and that is the protection of our community's health and making sure that we can provide the greatest skill to improving the health of people. So let me start and talk about some of the issues that, as we look at the nation and we look at healthcare in the nation, Florida's gotten somewhat of a bad rap in many ways. We at the Florida Hospital Association have been concerned about that. But a lot of the changes that we see that are occurring are not as unique in other states as they are in Florida. And for example, the largest population of age 65 to 85 are here in the state of Florida. And from a Medicare point of view, and from a healthcare percentage point of view, that's the largest consumers of healthcare, because as we age, we have more health problems. And more than 10% of the nation's uninsured, roughly 1 in 4, 1 in 5 Floridians, is uninsured. So we have a significant population of uninsured in our state. I think we rank second or third in terms of the states with the most uninsured population. And more than 1 million undocumented immigrants that are still showing up in our emergency rooms, looking in physicians' offices for care that they need when they become ill. And then as we look at the ongoing risks and the ongoing issues that all of our organizations face around some lack of tort reform that causes a significant amount of defensive medicine, and part of the issues around the Amendment 7 and several other issues have caused problems for us in the ability to recruit physicians and to retain physicians in the state of Florida, because there are some specialties that have significantly high medical malpractice insurance that other states don't have that burden. So as we look into the future, Florida needs to improve. We, as a organization, as a collective organization of healthcare systems across the state, we have some problems areas. Some folks are doing better than others. So it's our interest as an association to focus on setting some goals. And those goals need to really look at being much more involved in having the metrics to measure what the performance of the various organizations, various hospitals, and physician practices are. And through that measurement, begin to look at and monitor how effectively we are doing against national standards, and beginning to compare ourselves across who are the organizations that are considered to be the best performers, where are the states that are the best performers, why are they the best performers, and what do we need to do as an organization, as a state, to be more effective in that area. We need to place Florida on the leading edge. We are the third largest state in the country. We have many wonderful things about our state, our environment, and our healthcare system is a top-notch system. When we compare against some of the standards, we're going to work on improving those. And then to give you some sense of strategy, we will target the sort of high-impact issues, and many of these come out of the legislation relating to readmissions to the hospital and infections, things that the federal government has decided that they won't pay for. And when you look at what the results of the services are, they probably shouldn't pay for them, and we need to work on improving those. Tailoring our efforts to specific needs for Florida hospitals, such as caring for elderly patients. When we have such a large population of elderly patients, it's the relationship between skilled nursing homes and hospitals and physicians' offices and hospitals that are often challenged in trying to find locations to help support our elderly. Secure partnerships nationally and statewide. so that we can look at identifying, benchmarking, and building the quality efforts that we've set out. Recruit a significant percentage of state hospitals to participate in quality efforts. Martha's going to talk about a couple of those, because we think that as a state, focusing on statewide efforts, it strengthens our voice and gives us a greater ability to be recognized and to show our improvements at a federal level. And engage all of our clinicians, physicians, providers, and all of us as members of the community in working through this whole process. One of the uniquenesses about this bill, different than the 1993 bill when President Clinton was focusing on healthcare reform, that many people refer back to, the uniqueness of this bill is that it's putting pressure on all of us to change, on the physician, the hospital, the insurance company, the large pharmaceutical organizations, and us as individual consumers of health. We all will have to take our part. We'll all have to change the way we live our lives to become more effective in terms of how do we manage our health care. And in securing funding to reduce the cost and the burden on our communities and on our organizations. So at this point, I'd like to turn it over to Martha to have her go through some specifics that Florida Hospital Association is working on.
Thank you very much, Steve. Before I begin, I'd like to express my thanks and appreciation to Janet Long, and to the Institute for inviting us to be here for this very prestigious organization, and for the panel discussions that you've been hosting on behalf of federal health care. So it's my pleasure to be here, and thank you for Steve for joining us here and representing our Board of Trustees this evening. Let me just make sure I know what I'm doing now. My part of the presentation is going to focus this evening on presenting to you the specific initiatives and collaboratives that Florida Hospital Association has implemented statewide in all of our hospitals, the opportunity for all of our hospitals in the state of Florida to participate in these. And you can see by this list, and going back to Steve's comments, the Board of Trustees established specific strategies and initiatives that they wanted our activities to focus in on very strategically, not just random programs, but hospitals are literally involved in hundreds of quality initiatives and patient safety initiatives. So these are all voluntary on the part of our hospitals. They are not mandated by the government in any way. They require resources for our hospitals to collect data and generate information, participate in meetings in order to evaluate and analyze the data that they collect, share information with other hospitals and organizations here in Florida and across the country. So this is a lot of work, and a lot of resources are required to do this. And I think it speaks volumes on behalf of our hospitals and our association that so many hospitals voluntarily participate in these things because of their desire, their dedication and commitment to delivering the highest quality care and the safest care possible to their patients. The four collaboratives began, the first collaborative, and let me speak just for a moment about collaboratives. Steve already mentioned to you that a collaborative is a great thing. It's a group of hospitals that are working together in one program. And of course that allows hospitals to demonstrate out in public, in front of the legislature, in front of Congress, their commitment and their dedication to quality and to patient safety. But the real meat of a collaborative, and this is very well proven in the scientific literature at this point, that hospitals working in collaboration with one another they are able to more rapidly and more effectively improve and change the way they deliver care than when they work in isolation. To me, that just is kind of common sense, that, you know, the old concept of two heads are better than one. Well, two hospitals are better than one, and that's why we have hospital systems that work in collaboration. But this is hospitals that might typically be in competition with one another for resources. Now hospitals believe, and it's the basic premise of these, is that we do not compete when it comes to quality. All patients and all citizens in Florida and across the country deserve to get the highest quality of care and the safest care possible, no matter what hospital they go to. So this is where hospitals work together and share information. If they have found something that has allowed them to make progress in particular areas in their hospital, they very generously and openly share that information and that knowledge with hospitals in other parts of the state so that they can benefit and learn from one another. So that's the concept behind collaboratives. In 2008, Florida FHA began the Readmissions Collaborative, and I'm going to explain a little bit more about these, but this is just the timeline. You'll see that in 2009, the CUSP, or Stop BSI, which is about hospital-acquired infections program, began. In 2010, FHA opened the PSO, the Patient Safety Organization of Florida, and in late 2010, 2011, we began our Florida Surgical Care Initiative. All of these go back to the initial strategies and goals that Steve mentioned earlier. And you can see that through these 4 collaboratives that we have already begun, and I expect there will be more coming along, that virtually every hospital patient in Florida is touched by an FHA quality and safety initiative. Our surgical care initiative was selected because 20% of our inpatients in the state of Florida undergo a surgical operation. That's more than 500,000 people every year undergo a surgical operation that requires admission to the hospital. That statistic doesn't even begin to touch upon those patients who undergo surgery in an outpatient setting. Steve already talked about the fact that Florida is the #1 state in the country with respect to the highest percentage of citizens that are 65 years and older. And in that age group, that comprises 43% of the patients that we serve in our hospitals. Healthcare-acquired infections is greatly discussed in the media nowadays as a leading cause of death in the United States. According to the Centers for Disease Control, 1.7 million infections occur in our hospitalized patients every year, and of those, 99,000 associated deaths occur. This is a huge priority in every hospital in the state of Florida. Of those infections, 22% of those involve surgical site infections, and 14% involve bloodstream infections. So that goes to our initiative on hospital-acquired infections. And then, of course, preventable readmissions. And I'll tell you a little bit more about where we're coming from with respect to readmissions. But some of the basic information about readmissions, preventable readmissions, is that 10% of the Medicaid population is readmitted to a hospital within 15 days of discharge, and 5% of our uninsured, which Steve mentioned, we have a very high number of uninsured people in our communities. 5% of this population are readmitted within 15 days. So there are opportunities there, and I think you can see that our collaboratives are intended to address some of these specific and unique characteristics of the communities that we serve here in Florida. I'd first like to tell you about the collaborative that we began initially in 2008 on preventable readmissions. What this looks at, and I believe, and I'd like to point out that Dr. Denise Remus is in the audience tonight. Dr. Remus is the heads up the quality program for Steve Mason in the BayCare system, and she serves on our Quality and Patient Safety Committee. And so it's nice to see you here this evening. And she can probably contribute to this discussion quite well. But I believe that in every hospital across the state, there are people like Dr. Remus who are looking at data that allows them to analyze the quality of care that's delivered in their organization, and they're always looking for opportunities in order to assess and evaluate and identify places within our organization that we can improve the care that we deliver. So when we began looking at readmissions in 2008, I assure you that our hospitals have been analyzing that data for many, many, many years. What we did through this collaboration was allow them to work together to create a forum for them to share information and work together. And what they're looking at are readmissions of patients who are discharged from the hospital and they come back with a similar diagnosis within 30 days of discharge. So obviously if someone's discharged and readmitted for an entirely different set of circumstances, then that is not part of this. These are patients who come back because there was an issue surrounding the medical need that was addressed in their previous admission. Florida was the first. Florida's the first for a lot of things when you read the newspaper, but we were the first to require, through our legislature, created the Florida Compare system, and this created public reporting of a number of data metrics about quality and patient safety, and readmissions is one of those that was made available to the public here in Florida. We were also the first to create a collaborative for hospitals to work together to reduce readmissions statewide, and immediately 107 hospitals, FHA members and non-FHA members, began working together in order to address preventable readmissions. At the time the collaborative was formed, the baseline data showed that 7.3%, or more than 100,000 patients per year, were readmitted to hospitals with potentially preventable readmissions. And $31,000 and 6.1 days length of stay for each one of those patients. So going back to the initial premise for tonight's program, when you do the right thing, when you deliver the quality care and safe care, it benefits the patient, obviously. It's the right thing to do, but it also benefits the organization in that we deliver more efficient care and we don't waste our valuable resources. This collaborative has been working together since 2008, and they have monthly conference calls where they meet together and share information. They continuously evaluate their readmission rates to see how they're doing and whether or not things are improving. A number of projects have been initiated by this group, most of which involve communication, sharing data with various providers, involving other providers from the community to work with them, such as skilled nursing facilities. Many patients are discharged from hospitals to long-term care facilities, and looking at those patients in particular to see how we can deliver care more effectively to those patients so that they don't require readmission to the hospital. Working with physicians and working with health plans and sharing information that has allowed them to learn a great deal more, that has allowed them to prevent patients from being readmitted to the hospital. The results are very impressive, and to date, readmissions rates have dropped by 11.3% statewide. For our congestive heart failure patients, the reduction was greater. It dropped from 12.6% to 11.2%. That doesn't sound like a huge drop, but when you're talking about large numbers of patients, you're talking about a great reduction. Acute myocardial infarction or heart attack patients dropped from 11 to 10.6%, and pneumonia from 5.6 to 5.0. These are very impressive data, and when you analyze them statistically, you'll see that they are very significant for improving the work that's being done in our hospital. The second collaborative I'd like to share with you is CUSP. CUSP stands for Comprehensive Unit-Based Safety Program, and this program targeted hospital-acquired infections, and initially set out to look primarily in our critical care units, intensive care units, at patients to prevent a central line associated bloodstream infections. For those of you who are not clinicians in the room, hopefully you have not been a patient in ICU. If you have, you probably had what we refer to as a central line. It's not just a peripheral IV that they typically put in when you have surgery. These are lines that go into large vessels in your body, and they have a significantly higher risk of morbidity and mortality associated with them if a complication occurs when these lines are being used. But they are very important tools for our clinicians to use in terms of treatment and diagnostics for these critically ill patients. One of the biggest risk factors is for infection, and when infection occurs in these patients, their risk for morbidity and mortality is very, very significant. It's a very serious type of infection. Some years back, there was a statewide collaborative formed in Michigan called the Keystone Project, and they set out with some very bold goals, and their initial goal was to reduce to zero the rate for central line associated bloodstream infections across the state. I will tell you, I was working in a hospital as an infection control practitioner at the time, and I thought they were crazy because at that time, my paradigm was that certain infections were pretty much risk factors for patients who were critically ill, and that you would not be able to reduce or drive down that risk to zero. That basically it was kind of a consequence of having your life saved, that you were at risk for certain complications and infections. That was a bunch of years ago, and I will tell you, my paradigm has shifted dramatically because of the work that was done between Johns Hopkins and the hospitals that participated in the Keystone Project. We learned, much to our amazement, that reducing the risk of infections to zero was not an unrealistic goal. And now you'll hear most hospitals talking about chasing zero, targeting zero, where we now believe that we have an arsenal of information, sharing information with one another, that reducing the risk to zero is a realistic goal in our hospitals. Because of the work that was done in Michigan, the Health Research and Education Trust funded a study in order to replicate the work that had been done in Michigan to try to see if it could be done rapidly and effectively in other states, or was there something unique about the work that was done in Michigan. And so they funded a study where they set out to identify 10 states outside of Michigan in order to replicate the work that had been done there. And Florida was fortunate enough to be one of the states selected to participate in this replication study. And we began the work in 2009. We immediately began, and I will tell you that Kim Strite, who is my colleague at FHA, headed up this program and has very passionate about the work that has been done here. She set out to try to identify 10 hospitals in the state of Florida that wanted to participate in this study, and overnight we had 10, 20, we had many more hospitals, 35 initially, that wanted to participate voluntarily. And so we asked permission to involve more than 10 hospitals, and we got it, and we were able to extend this study to 35 hospitals and 69 patient care units. By December of 2010, the central line associated bloodstream infection rates fell from 1.65 per 1,000 line days to 1.23. That figure represented a lot of people who didn't have to stay in a critical care unit, receive antibiotics, and undergo significant increase in their level of illness. It also represented a certain number of lives that were saved through this collaborative because of the mortality rate associated with central line associated bloodstream infections. In March of 2011, and I get cold chills when I say this, but 27 of the 34 participating hospitals had 0 rates of central line associated bloodstream infections. I will tell you that the work that's going on in this collaborative, even though not every hospital in the state of Florida is participating formally in this collaborative, this is the kind of work that's going on in every hospital across the state of Florida, where we are getting closer and closer to eliminating certain life-threatening infections in our patients. And this is work that I am very proud of on behalf of all of the hospitals that FHA represents. This is a collaborative that really focuses on leadership and the culture of safety, and allowing everyone that works on behalf of our patients to challenge one another, and not be worried about approaching a physician. If you see a physician, if a nurse sees a physician that is not following appropriate protocol because they are busy and they got distracted for a moment, they call on them and say, let me remind you about the protocol or whatever. And the physician does the same with the nurse. Everyone that's involved in the care of the patient advocates on behalf of the patient with respect to safe care. This has become such a tremendously successful program. It is now expanding to another site of infection, which is catheter-associated urinary tract infections, which is the most common type of healthcare-acquired infection. It is also expanded outside of the ICUs into the regular medical surgical patient care units. And so this is a very, very successful program. The third that you saw in our timeline is PSO Florida, which stands for Patient Safety Organization. And I will share with you, this is a little different. This is an opportunity that has been afforded now by the federal government to create a forum for hospitals to work together in order to comply with the various laws that have been put into place, some of which made it difficult for hospitals to share information about their analysis, their improvement activities for delivering quality care and safe care. I'm sure you're all familiar with the various forms you sign when you see your doctor and you're admitted to the hospital that makes you aware that the hospital will not share information with anyone other than those folks that you designate that they're allowed to. Now, we do have the ability to conduct quality studies and to analyze and share information amongst ourselves for those purposes, but it is difficult sometimes to do that and to comply with the laws in order to share information outside of our organization. So the PSO Florida allows hospitals to learn from one another, to share information, to analyze data so that they're comparing apples to apples. They use standardized data methods. And so this is a tool that many of our hospitals are taking advantage of in order to further study and improve the care that they deliver in their organizations. The last initiative and collaborative that FHA has embarked upon is the Florida Surgical Care Initiative. This one I'm the lead on. I'm very proud of the work that we are just now beginning to embark in this collaborative. We began a partnership with the American College of Surgeons to improve surgical care in Florida. The American College of Surgeons is the foremost expert with respect to quality care. They are comprised of surgeons that are fellows and are certified in surgery, and they have been working for many, many years, and they developed about 10 years ago a program called the National Surgical Quality Improvement Program, and we refer to it as NSQIP, the acronym. This program has received a great deal of recognition across the country in that the hospitals that were participating in this program improved care very, very rapidly and preventing complications, infection, and mortality in their patient population. The problem with the NSQIP program is that it's quite expensive and it's quite labor intensive. And there were about 180 data elements that a hospital had to abstract from the patient record and report into this. And as I mentioned, there are many, many mandatory and voluntary quality improvement programs that our hospitals are participating in. So one that requires a minimum of 1 FTE time from their surgeons to do something in addition was a very difficult thing for many hospitals to make a contribution to. So we began working with the American College of Surgeons to see if there was an opportunity to take what they had learned in the NSQIP program and modify it so that it would require less of data requirement, and in order to participate in this collaborative and benefit from this program in partnership with the American College of Surgeons. And that's exactly what we have done. This focuses on 4 high-impact areas that are important in our hospitals: surgical site infections, urinary tract infections, colorectal surgery outcomes, and elderly surgery outcomes. These are all in the context of patients that undergo surgery in our hospitals, and elderly surgery was a particular importance to Centers for Medicare Services, CMS, the federal government, and they wanted to know, how do elderly patients do when they undergo surgery in our organization? So they created this special track. We launched this program about a year ago. It was in May of last year when we launched it, and the results have been phenomenal. And I'd like to share with you a little video that was put together by a number of champions in Florida that were trying to help spread the word about the Florida Surgical Care Initiative and the important work and the recruitment of hospitals into this initiative. Take just a moment to shoot. Well, what happened? I might need you. Oh, no, I didn't follow instructions here. Let me see if this works. There we go.
Providing quality health care is the most important thing we do. That's why we strive to improve health care every single day for our patients.
When complications occur, our patients pay the price. Our hospitals also pay the price. And increasingly, policymakers are looking to tie payment to publicly reported quality measures. Our future depends on providing the best possible care for our patients.
Quality is our top focus. As caregivers, it's vital to all we do, and we need the best tools and collective action, both within our hospitals and in our state, to ensure we provide the best possible care for our patients.
Hospitals and doctors working together is the most effective way to improve care. That's why the Florida Hospital Association and the American College of Surgeons developed the Florida Surgical Care Initiative.
This initiative is a statewide collaborative focused on improving the quality of surgical care in Florida. It's based on the American College of Surgeons NSQIP program, the recognized gold standard in surgical quality improvement for the ability to improve surgical outcomes. 9 of the top 10 hospitals on the U.S. News & World Report Best Hospital Rankings participate in NSQIP. Studies show that every hospital that takes part in American College of Surgeons NSQIP prevents between 250 and 500 surgical complications per hospital per year. Florida's hospitals have the opportunity for similar improvements in care.
FSCI focuses on 4 measures, which will provide actionable and high-impact opportunities for quality improvement. It allows my hospital to work with and to learn from other hospitals around the state. I'm confident that by working together, we will see significant improvements in quality, as well as healthier patients and lower costs associated with treating complications.
FSCI uses data from a patient's medical chart, not from the administrative form used to file an insurance claim. It's risk adjusted and it includes 30-day outcomes. That means we'll know what happened to our patients after they left the hospital. We can only get better if we have the best possible data and tools. We want to do what's best for our patients, and FSCI is that tool.
More than ever, Congress is looking at geographic variation in healthcare cost and quality across the country. FSCI will help us become a national leader in positive surgical outcomes, and it will help us return our patients to better health as quickly as possible. Every Florida hospital needs to join in this effort.
Well, if I can, let's see, there we go. I'll highlight some of the key points that were included here. This was a program developed by surgeons. Many times the government develops programs and they impose those on our hospitals. This is an opportunity that we had to work in partnership with the College of Surgeons, because who better to determine the best way to improve surgical outcomes than surgeons who are committed to using data in order to evaluate and analyze and improve techniques and processes and benefit patients by improving their outcomes. Another unique feature is that this data collection does not end the day the patient's discharged from the hospital. The hospital actually reaches out to the patient and to the surgeon 30 days following discharge, actually 30 days from the day of their operation, to see how they did, because we know that length of stay sometimes is short and a complication may occur in a patient after their discharge. They see the physician, they get a prescription for maybe an antibiotic or some other type of medication, or they may be readmitted to another hospital and be lost to that hospital if they were to limit their analysis of the data just to the time when they were discharged. So this actually requires that the hospital goes beyond that discharge date to 30 days, which we know from the literature is when most complications will have occurred, and collect that information so we have more accurate and meaningful data in order to analyze the care that's being delivered. We have reduced through this program the data collection burden from a full FTE to a half of an FTE or less. Some hospitals have very sophisticated electronic medical records where they're able to extract a lot of this clinical information out of the record. I believe BayCare probably has one of the finest in the state, and so it makes it a little bit easier. But there are other hospitals that are still struggling to implement electronic medical records, and they have to collect this data manually by having a nurse or someone otherwise qualified to go into the record, review it, and extract the data. So reducing that burden was very important, and this requires less than 40 data elements to be collected as opposed to 180 in the full NSQIP program. And the reduced enrollment fee, the enrollment fee for the full NSQIP program was over $35,000. Our enrollment fee for FSCI was $8,000 per hospital. The response to releasing this was overwhelming. We believed that this was an exceptionally positive program, but we were very, very pleased when within 3 months 102 hospitals had signed letters of intent to participate in this program. Keep in mind that this was a program that had to be built along the way. This did not exist. It is now the largest state collaborative for surgical care improvement in the country. We're very proud of that. And we had quickly 102 hospitals said they wanted to be involved in this. And in March of this year, the first cohort of those 102 hospitals began to implement and began to submit data to the American College of Surgeons. And so very soon we hope to have data that's going to begin to guide and direct us in terms of how we will begin to improve care and see results. In the meantime, though, these hospitals are all working together monthly in monthly collaborative calls, learning from one another already just about things that can be done in order to improve care. Another thing we were able to do was through the Blue Cross Blue Shield of Florida, they decided initially to fund the first year 50% of the enrollment fee for our hospital. So instead of $8,000 per year, it was $4,000 per year. And they made that commitment of $400,000 to us for 2010, 2011. However, they were so impressed by the commitment of our hospitals, the rapid sign up for this program, that they've extended that commitment to 2 years. So they've now made a nearly $1 million commitment between the enrollment fee grants for 2 years. They've also funded our kickoff meeting and a number of other in-person meetings that allows hospitals to get together and work in collaboration with one another. We also are told just recently that CMS is now formalizing a rapport with the relationship with the American College of Surgeons. So it's very likely that they will adopt a program like FSCI as early as 2012. So this allows the hospitals in Florida to get ahead of the curve before this becomes publicly reported information. I think you can see by the different collaboratives that are going on just through FHA, in addition to that, all of the other work that our hospitals are doing in order to improve care and create safe environments for their patient, that we are making a difference and we're getting results. As I said earlier, all of our programs are open to every hospital in the state of Florida, not just our members. Our members and our non-members are collaborating together. We have built key partnerships with providers, Blue Cross Blue Shield in Florida, payers, and regulators. The American College of Surgeons has turned to be an excellent partner for us, not just in the Florida Surgical Care Initiative, but also in the advocacy arena. We're establishing a culture of collaboration that will sustain and spread the culture of patient safety for many years after, as these collaboratives evolve and change and grow, we believe this culture of collaboration will continue on. And we've been able to secure funding if the payers believe that it's cost effective to deliver high quality care and safe care. That sends a very strong message, and they're willing to invest in this as well. So that concludes my portion of the program, and at this point, we'll turn it to Janet for questions. Thank you.
Thank you so much for that excellent program. And for those of you in the audience who may have questions, if you write them down on the yellow sheet that you were provided with when you came in, we'll be happy to try and answer them for you. Steve and Martha, thank you so much for participating this evening in this effort to try to educate and inform people about what's going on in our healthcare systems, not only in Florida, but all over the country. And maybe we could just clarify a few things that I think I heard you say. This initiative that you've started on, it's true that you've started to compile this data electronically and share it among the different hospitals, yes or no? Is that true?
Well, with respect to the Florida Surgical Care Initiative, the data is generated by each hospital, and it goes into a database with the American College of Surgeons. Hospitals that would like have granted permission for FHA to have access to their aggregate data, and so we can begin to identify state trends. We'll know where our baseline was when we began, and we'll be able to evaluate trends for improvement as we make progress through this initiative.
And so as you begin to collect that data and it filters down, at what point do you think that you'll have an opportunity to digest the bottom line cost and the savings that have been incurred as a result of quality?
Well, I believe we've already been able to do a lot of that, just because there's been a great deal already published in the literature about the cost savings associated with preventing complications by lowering length of stay, preventing readmissions. There's been a great deal of work already done. So we believe that it is cost effective. Now, there is always a cost. All of these initiatives require people, they require resources. So hospitals are investing in this, but they're doing it because it is the right thing to do. They believe and they wholeheartedly want to deliver the highest quality of care and the safest care to their patients. But there is we believe it will ultimately pay back by preventing complications.
So let's talk a little bit more about cost, because we're all involved and care about that so much as we hear about the spiraling cost of health care. And with the shrinking revenues that we have now in our various levels of government, in Pinellas County especially, we have a huge homeless and uninsured population in this county. And so rather than getting their health care through an individual provider, they're going to the emergency rooms in the hospitals. How is that affecting your bottom line?
And I can speak from a perspective from what we experience at BayCare. We're a not-for-profit healthcare system, and
Speak up, please.
Okay, can I get a little bit better mic? A little more mic. We are a not-for-profit system, and in 2009, we provided about $160 million of traditional charity care and uncompensated care. In 2010, that amount has grown to $185 million, and we're expecting to be somewhere around $200 million of charity and uncompensated care. Now, those are dollars that are provided to the homeless population or people that have no resources that need care, and also for individuals that show up with diagnoses that are Medicaid recipients or have county welfare programs, and the difference between what we're able to receive from Medicare or the county and what the cost of the service is. So when you look at that, it's a fairly complex and a large portion of a healthcare system's budget. And as I said, that number isn't going down. So as we've looked at it, it's not about whether the dollars are going to go down, it's how do you use those dollars more effectively. And the point that you're raising is one around emergency care. We all know that the highest point of care is in the emergency room, because there are federal laws and other requirements that as soon as a patient enters the emergency room, we have to rule out anything possibly that could go wrong with a patient. And the average cost when you walk in the door of an emergency room starts at about $800 or $900. And the average price when you walk into a physician's office or into a clinic starts at around $200. So to me, it's a lot about math. If we can change the way the structure of service is being delivered, so we move the front door for care from the emergency room to a clinic or a physician's office, you have the ability to take care of more people for the same dollar. And that's a large part of what most of the healthcare systems in our marketplace have been working on for years. Health reform wasn't an original concept when you talked about trying to change that point of care from the emergency room to the physician's office. The key is changing how the payment occurs so that the physician is paid effectively to be able to see more people in their office and to be compensated effectively enough. And that's why the insurance side of this reform, I think, will be important. It remains to be seen how it plays out, but That's really a critical part of what this reform package needs to address.
Well, you talked about the reimbursement rates, both for the hospital and for the physicians. Explain for our audience a little bit how that works and what you see happening on down the line with the changes in Medicaid that our legislature has just enacted this last session.
Well, let me address this whole concept of cost first, because I think it's misunderstood. When the federal government, and to a certain extent the state government, talks about reducing cost, they're reducing the cost of the program, which is the revenue of the physician and the hospital system. It has nothing to do with the true cost of healthcare, because that's the cost of what it costs to provide the services. So as we begin to look at the changes that are occurring, the cost of the healthcare service hasn't changed, but the revenue that the physician or the hospital will receive has changed and been reduced. And part of the 12% cut that went through the legislature from a Medicaid point of view, part of that relates to the reduction in the payment that will go to the hospital and to the physician. And it's our challenge then to figure out how do you reduce your cost and manage to be able to still provide a very effective, high-quality level of care for the difference in terms of the price. So when we talk about cost, it's different from the provider of the service than it is from the legislator that's legislating the service. You know, we realize that the economy of the state of Florida has been challenged in the last several years. So, you know, I think the legislature did a great job of coming to a medium ground in terms of a reduction. We knew that from a FHA point of view, we knew that we would have to sustain a cut because education and every other element of the budget was going to be impacted by this. And so I think there was a great collaboration between the House and the Senate and the healthcare industry to come to the point that we reached.
Okay. Excuse me. This question is for Martha. In what ways are the programs that you talked about related to the federal health care plan?
Well, they're integrated into healthcare, therefore they're related. I think that the healthcare plan ultimately, in a very simplistic way, intends to expand access to care for people in this country. So in that sense, it doesn't relate at all. But there are so many aspects of it with respect to reimbursement. And as Steve mentioned previously, certain types of care is not going to be reimbursed any longer. And so if we don't do a good job, if patients are being readmitted to the hospital, and that could have been prevented if we had delivered care more efficiently and prepared the patient better for discharge during the first hospital stay, and they don't have to be readmitted, then we will do better with the resources that we have, because the federal government will no longer compensate hospitals for the care of patients when they are readmitted. Certain complications, if a patient develops certain infections, healthcare-acquired infections, those diagnoses will not be paid. So it's cost-effective for hospitals to prevent them from occurring. So quality care is the best care that we can deliver, but it's also very important for us to minimize those aspects of care that we will not be reimbursed for. So from that perspective, it does relate.
Thank you. Okay, this next question is also for you, Martha. For Medicare patients, the use of diagnostic-related groups seems to provide incentives for hospitals to shorten hospital stays. Is this issue being addressed?
Well, I'm going to let Steve answer that question. That's more operational. The answer is yes, but I think Steve can probably explain that better than I can.
Repeat the last part of that for me.
Is this issue being addressed?
No, the segment just before that.
Sorry, I
please.
couldn't help
Yeah.
myself. For Medicare patients, the use of diagnostic-related groups seems to provide incentives for hospitals to shorten hospital stays. Is this issue being addressed?
The use of diagnostic-related groups is a way of coding and categorizing what a physician has done on the patient's behalf when the patient's in the hospital. So it really is a measurement and a way for us to determine how effectively or how that we can price out the care that we're delivering. It's not really a means necessarily to an end. We have this very strict set of requirements that as the physician goes through the process of deciding what's wrong with a patient, he or she chooses, based on the description of what's wrong with the patient, the DRG that fits that particular disease. So it's not the DRG that's being used in any way to change the way care is delivered. Care is really being addressed more through physicians looking at evidence-based best practice. And we're beginning now, in the last 10 years, have seen a lot more evidence-based practice that's documented, where you determine that if you do this same process over and over again, the care will improve. So physicians are looking at those evidence-based best practices as guidelines for the delivery of their care. They will be continuing to use the DRG system, but it's really around the guidelines that the physicians in the hospitals have looked at for care delivery. That's the mechanism that gives the ability to change and reduce cost.
Okay.
I will just add to that, though, that hospitals are not paid by the length of stay. I mean, obviously, that's for those who don't understand
They're
the whole
not.
DRG system. When that was system implemented years ago, so it behooves a hospital to deliver care efficiently and get the patient back home and as quickly as possible. But of course, we have to balance that with making sure we don't discharge them too soon.
What she means by that, on average, a particular DRG would be that you would be paid for the DRG with an estimated length of stay. So if the estimated length of stay is 4 days and you have a patient that's there for 8, on the 4th day, the hospital is no longer being paid. The last 4 days are being picked up in this uncompensated care category that I described earlier when I talked about $185 million a year of charity and uncompensated care.
And Janet, that just is a further emphasis on the need to deliver quality care, efficient care, and prevent complications. Because typically it's a complication that can keep the patient there the 8 days instead of the 4 days.
So is that $185 million that you're talking about, is that just your system? Or
Yes.
is that, I mean,
It
I'm
is.
thinking, God, that
Yeah.
number's gonna be astronomical
It is, and if you looked
statewide.
at astronomical, I don't know what the number is statewide, but we have about 1/3 of the market share. So if you looked at that on average as 1/3, then you can do the math on it.
Okay, all right, next question. This is for Martha, and it is, since Florida has large numbers of 65+ patients, many of whom probably have Medicare, does the high number of readmissions have anything to do with federal regulations that might force hospitals to discharge early? The government says stay is long enough based on statistics and not the patient's well-being.
Well, I don't think so. I mean, I think what you're saying is if they're on Medicare and say a scenario occurs that we've maxed, the patients hit this place that Steve sort of described as the number of days that's sort of built into that DRG, would we discharge them irregardless of their condition at that point? And the answer would be no. We absolutely do not. There's a responsibility to the patient to make sure that they're ready to be discharged. So,
yeah, I mean, that is a continuing challenge, and particularly if you have a patient that needs skilled nursing or a particular type of care, and the certain times of the year, all the skilled nursing facilities in the county and in the region are pretty maxed out in terms of capacity. So we'll have patients that stay in the hospital much longer beyond the DRG. We can't give up the responsibility for the patient until we have an adequate level of care to move that patient to when they're capable of doing that. And it is a challenge when you have homeless individuals or undocumented individuals from other countries. We've had people stay 3 years because we have no place to discharge them because they're undocumented, no one will take them.
Well, Mr. Mason, that leads us into, I think this might be a little bit of a trick question for you, but it's in two parts. The first part is, how much do you anticipate the 12% reduction will cost BayCare? And secondly, how does the 12% reduction increase access for the poor?
I'll answer the last part of the question first. I don't think it increases any access at all. Our Medicaid eligible recipients in the state have grown. The economy has not helped us there, and there's only so much money in the state budget. So as you can look at saying we're only going to pay for this amount of Medicaid, that doesn't mean that there aren't people that need to have or are eligible for Medicaid that couldn't get on the Medicaid roll. So that part of it doesn't change. The amount of 12%, I think it's going to impact us for the remainder of this year, for half a year, at about somewhere around $11 million, because the whole state has been fortunate that there was some stimulus money, FMAP money, that got us through the first 6 months of the year, so that goes away. And if you looked at it on an annualized basis, which would be 2012 for us, it's a $39 million reduction of services. But it's, you're looking at a $2 billion revenue base, though. I mean, so we're a very large organization, the second largest employer in the region, right behind Publix. So it is a significant aspect that we're now working on, trying to figure out how do we reduce staff or do what we need to do in order to accommodate what we think will be a bigger impact in 2012. I will say that I think the greatest thing that the legislature did was to preserve the medical needy and the Meds AD program that was at one point in time on the chopping block. And what I think the legislature, and I know one of our senators here understands very well, that the medical needy program is really helping the uninsured, the working poor, the people that are underinsured but are working, that aren't at a level where they are making too much money to qualify for Medicaid, but really don't have the resources to be able to provide and support the care. And that medical needy program was very important for us.
Okay, this is again for you, Mr. Mason. The Florida legislature just reduced minimum staffing levels in long-term care. Do you foresee that this happening in acute care facilities as well?
I'm going to ask Martha to answer that first. She's, as our vice president responsible for nursing, she's been involved with the legislation over the past several years, and I think can address that staffing question. I'll follow up if there's anything else.
I will do my best and then you chime in. The state Florida doesn't have mandated staffing levels for hospitals like they do for nursing homes. Hospitals are held accountable for the outcomes of care we deliver. We have to provide the level of staff that's necessary in order to provide optimal care to our patients. It is really an equation that cannot be mandated because the acuity of hospital patients is constantly changing when they're admitted to the hospital or immediately following a procedure. Their acuity may be extremely high, requiring an intensive care unit or some other type of specialized care. And then as they are in the hospital and they begin to recover, their acuity or how sick they are and how much care they require may change. And all of that is being constantly evaluated and adjusted on a shift-to-shift, day-to-day, patient-by-patient basis. So mandating that by the legislature or mandating it by policy within our hospitals, not through state policy, but through even internal policy, is not a realistic a way to do that. So we do not foresee that the state would be interested in trying to mandate something of that nature, because at this point we're being held accountable for the outcomes of our patient, the quality of care that's delivered.
We've got a great deal of confidence in our nursing leadership and in the talent of our nurses, and spend a lot of time focusing on this issue because it's important to good patient care that you have an adequate number of nursing support. We don't staff with a complete RN force because we like our RNs to be involved, engaged in care, and not engaged in some of the other aspects of providing basic care and comfort needs for the patient. And if you look at probably the law that the state that has gone the farthest in this is California, and we've studied that California law, it requires that on every shift, on every unit, that you have a appropriate number of RN staffs. And I know from talking to my colleagues in California that none of them are ever following that law, because the challenge is if you have a unit that requires X number of patients and there's fewer patients on that unit that day, the law technically is requiring them to staff that amount of patients, which isn't very effective from a productivity point of view and an efficiency point of view. And because it requires RNs, it has the RN doing much of the work that a nurse's aide would do and others, which really isn't the appropriate use from a professional point of view. I mean, these nurses, we have very few of them. We've got a nursing shortage, so we want to use their professional skills in the most effective way. And from a staffing point of view, we think we're able to do that much more effectively than could be legislated by the state.
Can I just add to that too, since Steve mentioned that California did mandate staffing RN ratios in 2004, and we watched to see the impact that policy had in that state, and there have been a number of studies that have been done at this point, and that policy has not benefited the quality of care, the safety of care in any way at all to the patients in California. It's been an extremely expensive mandate. I believe, and as a registered nurse, I will say I believe it detracted from the professionalism of nursing to make their own judgments about the level of care and staffing that was required for various patients and how to adjust for that. And so it's kind of discouraging that even with the investment and the loss of professionalism, the patients did not benefit at all. So we hope we don't have to repeat that kind of bad policy in Florida.
So this question is for Mr. Mason. Please, Mr. Mason, mention some ways that hospice care may be affected by the new federal plan. Will hospice care coverage and the payment of it be adversely affected by the new federal health care plan?
Now, I can't speak to the reimbursement being affected because, you know, the plan talks about going into bundling, and it's so ill-defined right now. I'm not sure that we understand what that's about. But if you look at reform, what the law, I think, is requiring organizations like ours to do, and I'll speak for BayCare because we've spent a lot of time thinking about it, it really puts us in a position where we're providing care from the physician's office all the way through on a continuum basis, and at the physician's office looking at how do you incent the physician to be able to provide care other than an admission in the hospital. You know, the challenge that we're faced with in this country is that for at least the 35 years that I've been in healthcare, we've been paid on a transaction basis. The physician gets paid when they see a patient in their office. They get paid when they admit a patient into a hospital. But if they're going to provide wellness services, or they're going to call a patient on the phone to see how they're doing and hire a nurse to do those kinds of things, there's no payment in the mechanism for that. Many physicians are doing that, but they're doing that just out of what they see to be the best practice. And what I think reform is getting at when it talks about population medicine and about bundling, it's getting at giving the industry an opportunity to move away from this sort of transaction, because we have all these silos. The physician has a transaction, the hospital has a transaction, every individual radiology organization has a transaction they charge, the hospice has a separate fee. So we're just a whole series of silos kind of connected together. We're not looking at how do you make this continuum of care really work for someone, and how do you find the way where you have two patients with the same diagnosis, and one patient, 68 years old, lives at home with her cat and has diabetes, she probably needs to be admitted in the hospital. Same diagnosis, 52-year-old woman that plays tennis 3 times a week, has a very strong family unit. She could go into an ambulatory surgery to home care that night, followed by home care for a couple of days. Those are all decisions that a licensed physician is faced with every day. And we're not giving them the availability to, in a smooth, effective way, to be able to cause those kinds of decisions to happen. That's how we're going to take cost out of this healthcare system in the country. And that's the part of reform that I really like, but it doesn't say that anywhere in the reform, but it does create the opportunity and the incentive for us as an industry to make this work, because I think we've got one bite at the apple to do this as an industry. We're going to end up as a single payer system like Canada, like the UK, like Sweden, and other countries where you get an opportunity to pay $11 a gallon for gasoline, and $6 of that's going to support the state-run healthcare program. You know, I think we have to, all of us, work together to look at how do we create a model of care that puts us in a position where you can begin with getting to the lowest point of care and making sure that everybody has adequate access to that care. And the emergency room is not the place to go to it. I do think the more that we just look at cutting the cost from a government point of view, and don't really look at how do we engage the physician in opening and expanding their practice to take care of people, we're going to drive more people into the emergency room, and the very opposite of what we want to try to do from a legislative point of view is going to occur. The cost of healthcare is going to skyrocket. And if you look at what the Congressional Budget Office and others have said, they have said just that the cost of healthcare between that period between 2014 to 2019 is just going to go straight up like an F-16 taking off. So, you know, I think we've got to come back, and I've got confidence in our legislative process that we will begin to look at how to tweak this law, how to make it work more effectively. But I think the industry, the healthcare industry, is beginning to figure out what it is that we need to do, and frankly, we're pretty excited about the opportunity to be able to make some of these changes.
It just sounds terrific, and I hope that we can all get engaged in being part of the solution. I'm not sure either one of you are the right person to answer this, but let me just try it on for kicks, and you let me know. We don't have a healthcare system. We have a disease care system that treats systems instead of the root causes. Doctors have become salesmen for a legalized drug cartel. Why won't the doctors address prevention with more than just lip service?
Okay. I don't buy into the drug cartel. I think that's very dramatic language, and it's the opinion of whoever wrote the question. I do believe that we have a sickness system. I do believe that our system is based on health care, not on health. And it's back to what I said. We're reimbursed for healthcare related things, and every time you try to, and it's hard to legislate wellness programs, because how do you demonstrate that you're really getting any value out of it? It takes 10 years if you're trying to work on getting the population to stop smoking, or to improve heart care, or to improve their diabetes or obesity. It takes 10 years to measure that. But that's what we've got to start doing as a country. And I mentioned earlier that most of what we do is what we call rescue care. People get sick, they go to the doctor, they have an accident, they end up in the emergency room. That's what we get paid to do. What reform is really talking about is creating the sort of medical home concept where you end up with a physician. And if you have a chronic disease, then let's focus on that chronic disease. Let's make sure that if someone has congestive heart failure, that we're following them. We've got nurses calling them every day. We've got monitors in their homes so that their quality of life can be, continuous over a longer period of time, rather than see the doctor sick, go in the hospital, not really have anybody following them other than going back to the doctor's office and then ending up sick and in the hospital again. We have these kinds of episodes that you can track. If we have management of chronic disease and then go back to the things that we always talk about, we need education in our schools, we need wellness, and we need opportunities. We need to spend time looking at how many, and we've done a great job in Pinellas County on bicycle trails and walking trails, and it's the environment that is going to make a big difference. We have a program where we have faith-based nurses that are engaged in 85 different parishes and congregations across the region. And when I talk to those nurses, some days they tell me, what we did today was we helped a lady get her front steps fixed because she couldn't get down the front steps to go to the bus stop, to get on the bus to go see her doctor. And that was a healthcare changing event. And I'm thinking, it doesn't sound like healthcare changing, but when you think about it, it really is. It's more than just the efforts of trying to manage someone that is sick. It's about how do we improve the quality of life and the quality of health life in our communities.
Okay, this question is for either of you. Does tracking of surgical outcomes for the elderly evaluate unnecessary procedures? And how long after surgery do you track the patient's health? And I think you said 30 days.
Yes.
Yeah. So can you address the part about, do you evaluate the unnecessary procedures that are done?
Well, the initiative that I discussed tonight does not look at the necessity of the procedure, but that is something that is evaluated in our hospitals. They have a variety of peer review committees and processes in place looking at that issue.
And do you think some of those issues are the result of physicians being afraid of litigation, and so there's all kinds of different tests that are ordered just to make absolutely certain they haven't missed anything?
I don't know that there's any evidence that directly leads to the fear. We have the concern because of the EMTALA law, when a patient goes into an emergency room, the patient came in with a headache and they had a migraine headache. If we knew that their history, and oftentimes our physicians don't have the history, the physician is thinking, if I discharge this patient and they go home and then have something severe because they have a brain tumor or something, that's going to be a litigious event, and we're going to be looked at by the federal government as well. So we'll do a CT scan. And so many times people will say, well, that's unnecessary care. Based on the way our structure is set up, I don't think it's unnecessary at all. I think that physician is making, because after all, their license is on the line here. So I don't think it relates to unnecessary care. I can tell you that in the hospital, we have very well-developed peer review processes that are evaluating the level of care in each of the divisions, orthopedic surgeons and the internists and those that work in the critical care units. They're evaluating the practice of their peers inside the hospital. I can't talk to that outside the hospital in the physician's office, and I think that's where probably the most variation is in terms of questions about procedures that are being done that maybe aren't necessarily to be done, but we have no data or no way of looking at and reviewing that. We do in the hospital, and you know, our physician organizations, and we hire medical directors in each of the divisions, and they evaluate the care that's being delivered, and if they have some questions about it, they'll sit down and talk to the physicians that they have questions about.
Thank you.
And document that.
Okay, now this questioner wants you to be very specific. What are hospitals locally doing to prevent staff-related infections as a result of surgery? And what percentage of patients get staph infections? And then please tell us which hospitals are members of BayCare. All of that.
I can't tell you the percentages of infections, and you know, I can get it. I can get somebody to address those answers. I have a couple of people here in the audience that probably could do a better job of answering that than I can. I can tell you that the Morton Plant, Meese Hospitals, St. Anthony's, and the 4 St. Joseph's Hospitals in South Florida Baptist are the facilities within BayCare. We spend a lot of our focus on infection control and infection management. I mean, it is a very serious issue, and particularly those infections that are methicillin resistant, you know, that staph infections that sometimes come in from the community, but because of the proliferation of antibiotics, the amount of antibiotics that we've used, we're finding very nasty bugs that are resistant to antibiotics. And when we have patients that come in or develop those kinds of, because of weakened immune systems, that really presents a great challenge. So we're very serious in terms of our focus and evaluation on patients that are being transferred from nursing homes or patients that come in that have been involved in an accident, to try to make sure that we can reduce the potential for hospital-acquired infections, and you know, that's a fairly major issue. I don't know off the top of my head what the cost is associated with that.
Let me see if I can be specific too, because I believe they wanted to know specifically about surgical infections and staph, and the percent of when the causative organism is staph fluctuates dramatically, whether between different parts of the country, different parts of the state, different ages of the patient. But I think it's probably important for all of us as consumers to know that the way that an infection occurs is that, you know, you can't sterilize skin. You can do a pretty good job on getting close to no bacteria, but bacteria normally live on our skin, and that's what they got to go through to conduct surgery, which is why so much now when they do endoscopic procedures, the complication rates are so much lower, because there's not a surgical wound in a site, an incision, or not an extensive one like there used to be. Now there's just a few little openings that they insert the tubes and do the surgery, so it's much, much better form of surgery. But the infection is going to be a result of whatever lives on our skin getting into that surgical wound. So the procedures for scrubbing the skin, cleaning the skin, disinfecting the skin, and then maintaining asepsis during the operation is critical. those are factors that are evaluated in this initiative and through normal epidemiology and infection prevention practices that are going on in hospitals all the time. Steve also alluded to multiply resistant Staph aureus or methicillin resistant Staph aureus. Important for consumers to know this is just one of many, many multiply resistant organisms that have evolved over time. You expose bacteria to antimicrobial agents, they will learn how to be resistant to those. And so a lot of it is antimicrobial stewardship. Earlier we talked about patients' expectations and drugs. Sometimes it's not the doctors that are prescribing them, it's the patients that are demanding them. How many people do you hear them say, oh, I've got a sore throat, I've got a runny nose, I'm gonna call my doctor and get him to call me in an antibiotic. And if they don't call them in an antibiotic, then they get upset. Well, that surgeon or doctor is being very responsible in many cases by not giving them an antibiotic, because we need to control for the inappropriate use of these drugs. The more we're exposed to them, sometimes it can take its toll, and the normal flora that lives on our body and does us a service. You can't have a sterile body and be healthy. Then we don't want those organisms to learn how to be resistant to the antibiotics that at some point we may very much need to save our lives. And if our bacteria are resistant to them, then they're going to have to bring in the big guns, which involves admission to hospital and IV antibiotics, a lot more difficult course of therapy than the Z-Pak. So we'll save those. But I think it's important to recognize that some of it is our stewardship as well as that of the surgeons. But preventing these infections is, you cannot walk into a hospital anywhere in the country now and not find alcohol-based solutions that are in the lobbies and in the hallways, and patients, there's signage up telling patients to expect and demand that their doctors and nurses and the people taking care of them are performing optimal hand hygiene. They're washing their hands, they're using these products. All of this is we're leveling the playing field and making it everybody's responsibility to be involved in the good care that they receive. And you didn't see those things going on in hospitals 10 years ago, but
or
you
even
do now.
5 years ago.
Absolutely.
Really. Okay, so when it comes to quality in patient care, is there a state in the United States that stands out? And how does Florida compare to the best of the best?
Depends on the ruler.
It depends also on what you're measuring. The new accountable care organization in the federal laws, the regulations that came out recently are talking about 65 different indicators that will make up the determination under accountable care about where quality is. There are organizations, I wouldn't say that I'm aware of a state, but there are organizations that have done very effective work in terms of quality improvement that we look at and benchmark off of. When you look at Intermountain Healthcare in Salt Lake City is an example of that. The Geisinger Clinic in Pennsylvania is another example that have very high quality marks. What generally we try to do, and most health systems do, is we look at setting a target to be in the 90th percentile, so that you're in the top 10% of all of the hospital systems or hospitals in the country in terms of your care. And we, about 5 years ago, set a target saying we're going to be in the 90th percentile, and we are there as a system.
Congratulations.
But in terms of looking at what people are measuring to be successful, there's a huge amount of variation in that. So it's hard to say that you can pick one set of standards at this point in time and use those set of standards to measure against 5,000 healthcare organizations across the country and say that somebody is number 5,000 and somebody is number 1.
Good luck with that one. Okay, this is a toughie. If the $500 billion reduction in Medicare is not achievable, How will this affect the entire program?
The $500 billion, I will assume that the $500 billion reduction is that portion in the federal law of reduction of health care. If you look at the federal law, the first $500 billion comes out of taking money away from doctors and healthcare systems, and then taking that $500 billion and spreading it across these exchanges that have more people in them. Theoretically, that's sort of a wash, because if you're getting money reduced and then somebody that didn't have insurance before that's showing up in your emergency room now shows up with an insurance card, technically that is pretty much of a wash. So between now and the end of 2014, the federal law speaks to that. After that point of time, the federal law then begins to, between 2014 and 2019, the federal law begins to look at reducing money around the readmission processes, many of the things that Martha talked about tonight, and that's where those dollars are going to effectively come from. And they look at the movement of putting Medicare and Medicaid at the same dollar amount. Medicare right now pays about 90 cents of every dollar of cost that a healthcare organization has. Medicaid pays about 46 cents of every dollar of cost. So as we look at it, it's my belief, maybe it's just my opinion, but I have to believe that legislatively, the Medicare dollar won't be at 90% of cost in 2016. It will be more at 65, 70 cents of cost, and the Medicaid and Medicare will come together at a different cost level. The difference between where the Medicaid dollar is today and where it's going to be in 2016 is what makes up that $500 billion of money, and I don't know how we're going to get there yet. The industry's got to figure out how to change the way it's delivering services, and it's got to figure out how it takes gets the insurance company that's now on a transaction basis, because you have to remember the insurance company has the premium, and the insurance company is paying for a transaction, admitted in the hospital or not. So if you admit fewer people in the hospital because you do a better job of managing those patients through prevention and chronic management, the premium is still there at that level. The insurance company built that premium on, let's say, 100 admissions. Now there's 80 admissions. Those 20 admissions end up being more profit for the insurance company. So the concept that hasn't been figured out yet, but we are talking with insurance companies about, the concept is that if you're going to shift your weight from this transaction-based to this sort of continuum of care-based, bundled, capitated kind of payment, the insurance companies are going to have to take and fund some of that transition so that we can pay the physician to start doing the things that they've always wanted to do, and we've always wanted to do that. Educate people, provide preventive care, manage chronic patients by having a nurse call them every day, or not every day, but on a periodic basis, and begin to communicate with them more effectively. Somehow we've got to bring dollars into that system, and I think that's where the legislative process can help. It's also, I believe, when I said earlier that this law puts all of us at the same position. Big pharma, equipment manufacturers that manufacture healthcare equipment, hospitals, doctors, third-party payers, and all of us as consumers of healthcare have got to play a role in making this change occur. We could save $500 billion if we all do that, but that's what I think our challenge is over the next 5 to 7 years.
Okay. So now, will patients be able to opt out of having their medical records put online? If so, will there be any penalties or punishments associated with that choice?
I'm not sure that I know what they mean by putting them online. I think there's this concept that we're going to have, that the patient record, this piece of paper, is somehow in its paper form online that could get passed out to someone. Where the record is, and we've been working, we're in the 6th year of a 7-year project of going from paper to the electronic world. And what's happened is the medical record storage location no longer exists. It's all in zeros and ones in a computer system. And they're discrete elements of data. So as we're treating a patient now, we're entering information into the computer, and that's going into a data field. And as we need information for the physician or for the patient, we'll go in and extract information out of the data into the format that gives them the kind of what you might have looked at in the past as a record. We reconstruct it in the form of a record. So all of that data is highly secured. We've got HIPAA regulations and all kinds of requirements that make that security the utmost level. And there's not any plan of putting any information online. The patient won't have to, we aren't selling the patient's record in any form. There's a federal law that doesn't allow us to do that for sure. So, I think there's a legitimate concern about the privacy of the patient record. And we all have those concerns, particularly any of us that our information has been stolen on a credit card and somebody charges something in New Orleans for a massive amount of money that you know wasn't yours, and you find out about that. That we have those kinds of concerns. I think that information security is going to be a challenge for us because we're going to get more and more down that pathway, and it'll continue to be a challenge. But I really don't think that people have to worry about what happens to their information. That information still belongs to them, just like the information on a paper medical record belongs to all of us. It's our information. We're custodians of that record. So we'll have to get permission from the patient to give it to anybody, just like we do now, in any form, whether it's electronic or whether it's on paper.
Okay, so now, are there any VA hospitals in the collaborative?
No, however, the VA system created the NSQIP system, so they are involved already in a different type of program with the American College of Surgeons. The progress, the improvements that they made in NSQIP is really what established that system initially a number of years ago. So they are very much partners and working in conjunction with the American College of Surgeons.
Well, don't you think it's kind of interesting that if you go in the military, you know how they do all those physicals when you get inducted or whatever they call that, and you get this little, almost like a credit card, but on that credit card is your entire medical history if it gets plugged into, I mean, let's say you go to Fort Bragg and you're there for a while, and then you go off to, I don't know, someplace else, Fort Campbell, and you get sick in Fort Campbell and you give them this little credit card and they put it in the thing and they got all your medical records. I've never quite understood why we can't replicate that. It seems to be so easy.
You know, it's a really simple concept, and I agree with you 100%. Why can't we replicate it? Well, you know, if you got out of the military and you had your little card, and now you go to work for Publix that has Aetna insurance. You now have an Aetna insurance card, but everybody in the military has one insurer. When you look at the number of people out there that change insurance every year, one year they have an Aetna card, one year they have a United card, one year they have none because they lost their job. I mean, it is a very complex structure. So to try to track all of that information, particularly because this industry has been on paper form. I mean, we are as an industry, when you look at other industries, we are way behind in the electronic world. And we're just now as an industry catching up. We're probably 50% of the way where we need to be, and it'll be another 7 to 10 years before we're at a point as an industry that you could be as effective as the banking industry, where, you know, we could both be in Paris and put our ATM card in and take money out in a different kind of a...
But you know, when you go to the doctor and they do blood work,
Yeah.
and then the next day you go to the hospital, oh my
And
God,
they-
they're doing blood work
Yeah.
again. If you had everything on the little card, they just put your card in there and they'd know already what you'd already had. You wouldn't have to duplicate that
If-
That's just one example. I can
It's-
think of millions with
I think it's a-
x-rays and CT scans and...
It's a great example. We today, from a BayCare perspective, across all 11 hospitals, have the ability to exchange information finally. And it's only been in the last 6 months that we've gotten through this 6-year process, or 7-year process that we're 6 years through, where if you went into the emergency room, your physician could pull up all of the information of anything that transpired in your record in a BayCare facility. We also have 1.5 million palms scanned. And I don't know if we have this very simple, looks like a little football tee. It's a little plastic thing. When you go in for admission now, we scan the palm of everybody's hand, which is a unique identifier. It's like a fingerprint. And what it does, it creates this unique identifier that gives us the ability to migrate every piece of information. If you went into an outpatient lab draw site in Ocala and we scanned your palm, we would capture that lab information and end up in your record in the computer.
Now, what if you went to New York City and got in an accident and you went to the Mount Sinai or one of those hospitals? Would you be able to exchange that with them?
No.
That's the problem.
Not yet.
Yeah, not yet. Someday we will. Someday we will, but, you know, we're you know, and you may be able to get to that if you have a universal health care, a single system, but the complexity of being able to do that across the entire country would be pretty significant.
Oh, come on, we can put a man on the moon. It seems like
I
we
know.
should surely be able to get that done if we really focused on it.
We are spending $260 million in that 7-year effort to go from paper to an electronic world. So think of every other healthcare system in this market around the country and do the math on that, and you realize that this is a very expensive transition.
Yeah, it would be interesting to see, though, if you could get that done, whether it would be a really significant cost savings that would make it worthwhile in the long run.
It will not be a significant cost savings on the electronic system itself, but what we learn from it will. What we learn from it, we're already seeing the kinds of things where you can finally look at data. You know, all of the data's been on a paper record in all these files. So if you wanted to try to pull together everybody's information out of a file that thick, that's unbelievably hard. If you wanted to look at all the people that had a gallbladder procedure last year in one of your hospitals, you'd have to hire a team of nurses to go through all of those paper records. Today we can pull all that information together. Now that you have that information, we're beginning to see things that we didn't know before because you didn't have the ability to look at it. So I'm very excited about what this offers to the ability to improve the delivery of care, to be able to change some of the things that we talked about earlier so that people can be treated in a more convenient way and lower cost level of care. And over time, I think that's where the savings is. The technology cost will get smaller, we hope, because it's significantly more expensive. We may be spent, before we went into the electronic record, we maybe spent 1.9% of all of our expenses on IT. We're now spending 3.5%, 3.7% of our expenses. So, you know, and that's going to grow over time. But I think it's important.
Progress,
we are making great progress, I think.
That's a good thing. All right, this is the last question because we're running out of time. How do you vision preventive health and disease management being operationalized, and are the economic incentives aligning with the strategy?
I believe that it's already being operationalized by a lot of systems. A good example is we have a very big home care division, and we can demonstrate when we have a congestive heart failure patient that's on a Medicare program, we can demonstrate that you can effectively reduce the amount of office visits and hospital visits because we put monitors in the patient's home that measures their weight and their blood pressure, and we've got a nurse that's talking to 50 patients at a time, just following what's going on and calling them up and seeing if they're taking their meds, if their weight changes, what's going on with their diet. We send a home nurse out to visit them. That's an added expense, but over the long run, we're seeing that is creating a significant reduction in the cost. And the last part of that question was?
Are the economic incentives aligning with the strategy that you just outlined?
Yes.
And the answer is yes. I want to thank you all very much for coming this evening, and for Steve and for Martha taking their time. David, you want to? All right, now just be still for one more minute. I want to tell you something. The Florida Community Health Action Information Network is sponsoring a similar program about the Affordable Health Care Act. What's in it for you? And it's tomorrow from 3:30 to 5 at the Hospice Center on Roosevelt Boulevard. If any of you have any questions, see me after the show. Hold on. David, thank you.
Thank you, Janet, and again, thank you, Ms. DeCastro and Steve Mason. I appreciate it was very good information. I want to thank the audience for some great questions. And if we didn't get to your question, and if you gave your email, if I may ask you to, we'll email those questions and forward your answers to those who we didn't get to. I think we got to the majority of them, but perhaps a few didn't. But we do want to respect your time, and thank you for coming. We hope that in future programs you'll come back and you'll tell your friends and neighbors about them. You can check our website, which is spcollege.edu, and click on the Solutions button for future notices of future programs, and we will notify you if we have your email, unless you want to opt out. So again, thank you, good night, and drive safely home.